As you correctly mentioned, when I started studying in Brussels, that was in 1992, and when I finished my medical studies in 98, 99, I ended up in the Department of Gynecology at the University of Brussels, as you correctly mentioned. And at that time, in 98, 99, we were doing in Brussels around 4,000 or 5,000 IVF cycles. And I can tell you already at that time, 80 to 90% of all the cycles were conducted with an antagonist regimen. So it means actually I grew up with antagonists even before they came into the market, because we were doing all the research at that time on antagonists. Now, if you go back in time and look into the antagonist, I think we had several milestones in ovarian stimulation. Now, the first milestone was in 1984. That was the first time where we realized that we have the feasibility, we have the possibility, through desensibilization, prevent a premature LH rise. Because we knew that in 20 to 30% of patients who we were stimulating, they had a premature LH rise and the cycles had to be canceled. And obviously there was no pregnancy because of that. So in 1984, we realized, oh, with the agonist, we can do that. Now, it took us to 1992, where the first meta-analysis published by Edward Hugh came out that yes, if you use a long agonist, or if you use an agonist as compared to nothing, that the pregnancy rates improve significantly. So basically in 1992, we understood, yes, it's working, and we improved the pregnancy rate at least by 7%. Now in 1998, it means it took more than 15, 16 years after the initial introduction of the agonist that we realized the best mode of treating a patient with an agonist is a treatment which is called the long agonist. Why a long agonist? Because you had to start the downregulation, desensibilization in the luteal phase of the previous cycle. So again, as you see, it has taken us 15, 16 years since the beginning of the introduction of the agonist that we realized and we understood which is the best way to go ahead. Now, after this, it was in 1999, as I mentioned previously, in 98, 99, we realized that, okay, now we have also the antagonist on the market. So maybe we should start also using the antagonist. What it does, the beauty of the antagonist is it generates an imminent, immediate suppression of the LH. And this is exactly what we are looking for. We want to suppress the LH immediately. Now, if you take a look at the stimulation protocols that we are having today, as you can see, we are having the long agonist protocol, where you start usually day 21 of the previous cycle. You have a suppression, which is usually taken 10 days to 2 weeks. After the downregulation, you go with the stimulation, you go with the final oocyte maturation, egg retrieval, and luteal phase support. Now, if you go with a short agonist cycle, you start when the patient is having a menstruation, day 1 or day 2, and the day after, you start the stimulation. And as you have seen, the meta-analysis by Selim Deya showed that the long agonist is superior to the short agonist. Now, with the antagonist protocol, it's a completely different approach. You stimulate the patient. Once there is an imminent need to prevent a premature LH rise, you administer the antagonist. As you can see, the rest is identical. Now, how is it feasible? Why did it take us so long time to have the antagonist? Now, in fact, the same time when we had the long agonist, or we had the GnRH agonist, we also had the antagonist available. So when we were looking to 83, 84 with the introduction of the GnRH agonist, we also had the antagonist. The only problem with the antagonist, the first generation antagonist, was that it was stimulating the release of the mast cells. So patients who received the first generation of the antagonist, they had severe allergic reactions, sometimes even anaphylactic shock. So this is why the first generation of antagonist could not be used in the 80s. Now, if you take a look at the hormone itself, the GnRH is a decapeptide. It consists out of 10 amino acids. In order to have a GnRH agonist, only one amino acid has to be replaced. Now, if you take a look at the antagonist, they had to change, as you can see, different colors in the second row. They had to change 6 different amino acids in order to have a GnRH antagonist. So as you can imagine, it's a very complex hormone to have a GnRH antagonist. This is also why it took many years to have a product which is blocking the receptor and which is not stimulating the mast cells in order to have no allergic reactions. Now, if you take a look at the mechanism of action between GnRH agonist and antagonist, it's very interesting to see the GnRH agonist, as the name is telling you, it is not suppressing the GnRH receptors. It's basically stimulating those receptors. It's an agonist. So what happens? The anterior pituitary is being stimulated and it's releasing the hormones. So you have initially a flare up. That flare up will take approximately 1 week to 10 days. At certain point, you have a desensibilization of the receptors. And this is where you have the downregulation, the suppression. Now, if you take a look at the antagonist, it's exactly doing what it's meant to do. What does it do? It is blocking the receptors immediately. As a result, you have an immediate suppression of the receptors. And if you take a look at the LH levels, you see an immediate suppression of the LH levels. And that's exactly what you want. You want to have an immediate suppression of the LH levels. Now, if you take a look at the endocrine profile, and Ut and Bernadette Manarts did a lot of research at end of 90s, beginning of 2000s, so 20 years ago. And as you can see, if you take a look at your endocrine profile, if you take a look at your LH, FSH with the antagonist administration, you see within minutes, you have a suppression of your LH. And that will take at least for 24 hours. So if you put the agonist and antagonist in one picture, you will see that with a long agonist, you have first a flare up, you have the desensibilization. After the desensibilization, once you have the suppression, you start your stimulation. With the antagonist, you stimulate the patient. Once there is an imminent need to prevent a premature LH rise, you administer the antagonist. Now, this is the basic physiology, but what difference do you observe in the ovaries of a woman who is being stimulated or downregulated with a long agonist or administered with an antagonist? Now, the antagonist patient comes to you at day 1 or 2 or 3 of the cycle. It means that ovary has been exposed to endogenous hormones in the luteal phase of the previous cycle. It means those follicles have been exposed to endogenous FSH, which starts to rise already in the luteal phase. So the moment you perform an ultrasound scan, you will see that there is an asynchrony. Those follicles, as you can see in the picture number 2, are not synchronized. They will be different in size. On the other side, if you're looking at a patient who has been suppressed and downregulated with a GnRH agonist, because there is a lack of gonadotropins, those follicles would be fully synchronized. And this difference is important because that will also explain the differences that we're going to observe in the next couple of slides with the outcomes which are related to these differences. Now, if you take a look at the initial study trials which were done in end of 90s, beginning of 2000s, we all seen that all patients, what kind of agonist you use, is it buserelin, loiprolide, or triptorelin? The moment you compare a long agonist with an antagonist, we see that the duration of stimulation is significantly shorter with the antagonist. Why is that? Because those follicles have not been suppressed. So they have already been exposed to endogenous FSH of the human body. Of course, if you have a longer stimulation with an agonist, you would also require more FSH. If you require more FSH, because you have also longer stimulation. On the other side, the initial studies which came out, they demonstrated that some countries, some clinics did have similar clinical outcome. But some countries, some clinics had significantly lower pregnancy rates if they compared agonists with the antagonists. And if you put them together, the overall was a difference of 5–6%. Now you might ask yourself, how is it possible that one country has better results than the other country with one protocol as compared to the other protocol? Is it the weather? Is it whatever is present there? The answer was very clear. The answer was that there was a learning process ongoing. Those sites who had participated in phase 1, phase 2, and phase 3 trials, who were experienced using the antagonist, performed better than those sites who didn't have any experience at all to use the antagonist. So that is what was the explanation in the beginning, that there was a learning process we had to go through in order to understand what is the best mode to administer the antagonist. And also, if you go back not very long time ago, 10 years ago, analyses in the US demonstrated that in the beginning, when the antagonists came to the market, we started using them for elderly women. We started using them for poor responders. We started using them for multiple repetitive implantation failures. So there were a lot of really bad prognosis patients who were initially being treated with the antagonist. And if you look end of 90s, 2001, 2005, so over the past 15, 20 years, this has been the reality. Also, if you take a look at the patients, mostly there were repetitive implantation failures. There were poor responders. As you can see, they had significantly higher consumption. They had lower number of eggs. And of course, the live birth rate was lower because this was a difficult population which was being treated. And also patients with repetitive implantation failure, the more failed cycles patients they had, the more we tended at that time to treat them with the antagonist. Now, if you take a look at the advantages between agonist and antagonist, I think you all know better than I do. If you use a long agonist, you will have 10–15% of the patients who will have this flare up and who have a cyst formation. Those who have been suppressed, they have obviously menopausal symptoms. They have these hot flashes, this emotional instability, I would call. And of course, as you have seen, the treatment is significantly shorter with an antagonist, and you reduce the dose of the gonadotropins. Now, I think it is very clear. It took us 14–15 years with the agonist to understand that the best mode of administration is a long agonist initiating day 20–21 of the luteal phase of the previous cycle. And this is something we were lacking in the beginning. In the beginning, we didn't know what is the best mode of administration. Which day should we start the antagonist? I remember those days in Brussels in 98, 99, we were speculating. We should start when the follicle is maybe 16 millimeters. We should start maybe when it's 10 millimeters. Maybe we should have a fixed protocol starting on day 3 or 4 or 5. So we didn't know how to start. So we were playing around to understand when is the best time to start it. Now, another beauty of the antagonist is obviously the administration of the GnRH agonist for the final oocyte maturation, because the agonist is displacing the antagonist from its receptors and it's generating an ovulation, which we are looking for. And that ovulation, now I will not go into detail, it obviously, by reducing the vascular endothelial growth factor, significantly reduces the risk of ovarian hyperstimulation. Now, if you take a look at the safety between agonist and antagonist, obviously, Maryse Bonduelle from Brussels published many papers on that topic that has been extensively looked at, and there are no differences. Now, the problem with this big question mark behind antagonists and the outcome came because there were meta-analyses published with contradictory results. Now, I have to tell you personally, I'm not a big fan of meta-analyses because I think they contain a lot of heterogeneity. I am more of a clinician looking to the facts and trying to avoid bias of studies. But I think meta-analyses, due to heterogeneity, they have always some bias concluded. Now, statisticians will tell you this will be diluted because of the high sample size and number. Still, I would be put a big question mark behind it. Now, if you take a look at the meta-analysis, the first meta-analysis came by the group of Lübeck in Germany by Michael Ludwig and Klaus Dietrich. It was in 2001, comparing agonist with antagonist, and the outcome was no difference. Now, the second one came from Egypt, Professor Mohammed Abul Ghar and Hisham Al-Inani. They published that it seems to have lower pregnancy rates. Was it 4 or 5%? 2004, Salim Deya came out, no difference. Then 2006, Hisham came back again, said, look, there is still a lower ongoing pregnancy. 2006, Kolobianakis, who was working with us in Brussels at that time, again published a paper, there is no difference. So it's very intriguing. You know, 1 year there is a difference, the next year there is no difference, then there is a difference, there is no difference. So somehow it's a little bit contradictory. Now let's look into detail what happened, why did they observe significant differences in the outcome. So mostly, I hope you are familiar with this meta-analysis. So this is the unity line. If this is not touching the unity line, it means the difference is significant. Now here, as you can see, looking to antagonist versus agonist, it seems, as published, that there is a difference of 5% increase in clinical pregnancy. That was in 2002. Remember, that was the first days when the antagonist came out. So I remember Carola Albano, who is the first author here, when she was working on that paper, that was in 97, 98, really the first days when the antagonist came out. So we were learning how to work with the antagonist. Now, Francois Oliven, that was also more or less the same time frame. It was, I think, in 98, 99, 2000. So really the beginning days. So it came out that there is a difference of 5%. Now then it was revised in 2002, and the difference became 3.8%. Now, further years, 2006, the difference remained around 4%, as you can see, 3.8 to 4%. In 2006, Stratis Kolobianakis did a meta-analysis, published a Human Production Update. And here, suddenly, the difference was not significant anymore. As you can see, it's touching the unity line. The rate difference was 2.5%. What they all agreed on is the fact that the OHSS risk was significantly reduced if you compare agonist with antagonist. And the Cochrane in 2011 again came out significantly less OHSS. And that was the case with all patients, but especially with the PCOS patients. So Hisham and Stratis, both of them agreed that the duration is slightly longer, the risk of OHSS is significantly less, and there is more need to interfere in case of OHSS with agonist as compared with antagonist. But of course, the question that we would ask ourselves, again, how is it possible? Two scientists, two clinicians asking the same question, but coming out with contradictory reports. So the meta-analysis in 2006, one of them Cochrane, the other one in Human Production Update, I think both journals, groups with a certain name and fame, they came out with different outcome. Why is that? So let's look in detail. So in 2006, the latest research which Hisham was looking at was in February 2006, because you could say maybe it was a different timing they were looking at. And Kolobianakis was looking in December 2005. So it's very similar timing. Now, Hisham included 27 studies. Stratis, Kolobianakis included 22. So you will say, of course, 27 is more than 22, so that must be more reliable. Maybe. On the other side, this study of Cochrane included non-peer-reviewed data. I think if you do a meta-analysis, it's important that you look to peer-reviewed data. That study included inseminations, but that was not the objective of that paper. The objective was IVF in antagonists and not IUI cycles. And as you can see, the numbers were higher because of that. But if you would exclude that, you come to this, and the primary outcome here was live birth. So most probably, if you see that, you would agree that Kolobianakis had the more objective approach to this publication. Now, it took 5 years longer, from 2006 to 2011, that finally Hisham came out with this Cochrane paper. that the use of antagonists compared with the agonist protocol was associated with a large OHSS, and there was no evidence of difference in live birth. So it took many years to finally come out with the outcome that antagonists and agonists have the same outcome. There is no difference in outcome as long as it's being correctly used. Now, over the years, many other publications came out, meta-analyses came out, and all of them obviously came out with the same live births and same findings and reduction of OHSS and so on and so on. Now, there are subgroup of patients which might benefit even being superior with the antagonist. For example, here that was a paper which was published by Toftager in EFRE 2016, demonstrating better outcome in women whose BMI is above 25, having a better outcome. Now, this discussion continued and still is continuing. Another entity of patients which is ongoing are the poor responders, but also here, as you can see, the results are comparable. Now, the question which we should ask ourselves is, how should we go ahead? When you're having an antagonist protocol, do you use a fixed or do you use a flexible protocol? Now, this study, which was again published by Stratis in 2010 in Fertility Sterility, compared the fixed and flexible, and basically he came out with the same outcome. There was no difference. So the fixed and flexible had no outcome. Meta-analysis also came out recently. There was no difference. There was slight favor, but no significant difference. The problem is still some patients who started day 5 versus day 6, they had the tendency to have a premature LH rise. So as you can see, the p-value is not significant, 0.06. If it would be 0.05, it would be significant, but 0.06 is obviously not significant, but there is a tendency towards 2. So if you start day 5 as compared to day 6, the result, the difference is not significant. However, there is a tendency towards. So the question rises, which group of patients would benefit to have an earlier administration of antagonists? So instead of fixed day 6, maybe starting on day 5. And the answer came by Frank Broekmans, who looked which kind of patients are having an early RH rise. And those are obviously patients who are hyper responders or high responders. So patients who have more than 9 to 10 follicles of 11 millimeters while you stimulate them within the first 5-6 days, they would be at risk to have a premature LH rise. So if you have a high responder, it is recommended to start on day 5. If you have a normal responder, then it's recommended to start on day 6. Now, of course, you could also argue, why do patients drop out in a certain treatment? Why do patients discontinue a treatment? Of course, there are various reasons. One of them is the physical, psychological. Of course, the financial aspect is also an issue, but we know that the main reason is the physical or psychological aspect where patients are dropping out. Now, if you take a look at the cumulative live birth, this is a Lancet paper from group of Bart Fauser published 12 years ago, comparing an antagonist with single embryo transfer with a long agonist with dual embryo transfer, at the end, the results and the chance of dropping out was significantly higher with the long agonist protocol. And if you take a look at the live birth, it was absolutely comparable. Now, an issue which many of us are dealing with or are faced with is the fact that we say, look, with a long agonist, we can plan our clinics easily. But with an antagonist, it is difficult because you start on a certain day, you have to trigger on a certain day, and you have to go for the pickup on a certain day. So we have no flexibility. So based on that issue, several studies came out to say, okay, what can we do for the cycle planning in antagonist cycles? Now, the first and easiest, obviously, would have been the use of an oral contraceptive pill. Now, oral contraceptive pill must be at least taken for 14 to 15 days, but it's very important that we realize that there is a washout period of 5 days. This is extremely important because if you take an oral contraceptive pill and you take it for 15 days and you stop it for 1 or 2 days and you start stimulating, most patients will not have started bleeding at that time. The hormones will be still suppressed. The endometrium still will not be ready to be bleed. So this is why we have to respect the 5 days washout period. This is very important. With an estradiol pretreatment, you don't need to have these 5 days because there is no progesterone in that. You just need 1 or 2 days and that's it. Now, the initial paper which came out on priming, pre-treating an antagonist cycle was from a good friend of mine, Renato Fanchin from Paris, where he published again almost 20 years ago that if you do estradiol priming, first of all, you can plan a cycle. Secondly, you synchronize those follicles more. For example, if you have a poor responder where you have a huge asynchrony with your estradiol administration, you can synchronize those follicles. And obviously, by synchronizing the follicles, you generate a pseudo-long agonist protocol. Why? Because the follicles will be synchronized, they will be smaller, the treatment will be longer, and obviously you would require more FSH, and you would have also more oocytes because you have synchronized more. And the same concept has been replicated again and again by many other authors. This is a paper published by Christophe Bloquel from Brussels, also 10 years ago. Same concept, estradiol pretreatment, no estradiol pretreatment, and the results were similar to Fanchin's paper. This is Isabelle Anguivarch-Levesque also from France. 10 years ago, they could avoid weekend work also completely. All of them came out with the same outcome, that basically you synchronize more, you consume more FSH, that's a fact, because the follicles will become smaller. It will take slightly, almost 1 day longer to reach the time of final oocyte maturation. And pregnancy rates similar. Again, this is from Christophe, 2012, repeated again. All of them show towards the same point, that you have longer stimulation, more FSH consumption, you synchronize more, and you can avoid weekend work. Pregnancy rates were comparable, and number of oocytes, they were slightly higher in this study, but not significant. Now, estradiol pretreatment is easy, straightforward. You just need 1 or 2 days of washout, and you go ahead, as you have seen previously. Another entity which can be used is, as mentioned previously, the oral contraceptive pill. Now, oral contraceptive pills have been used for a long time in the field of ART to plan, also to synchronize. The question is, can we use them in an antagonist setup? Does that reduce the chance of a pregnancy? So the first meta-analysis came out by a good friend, George Griesinger from Lübeck in Germany, 2018. And as you can see here, it came out that there is no difference, no significant difference if you use contraceptive pill for cycle planning or to synchronize as compared to nothing. Now, a few years later, so that was 2008, we are 2010, so 2 years further, a couple of other studies were included. And as you can see, suddenly it became statistically significant, meaning if you use a contraceptive pill as a pre-treatment, you seem to reduce your pregnancy rate again by 4 or 5%. Now, again, let's break down that meta-analysis, which was published by George Griesinger. So they had 34 studies, 27 excluded because of various reasons, as you can see. Then they excluded 3 more, then they included 2 to them. So they ended up with 6 randomized controlled trials. The problem with these 6 randomized controlled trials is they included in these 6 trials normal and poor responders. Now, these are 2 different entities of patients. 3 out of the 6 studies had less than 30 patients. They used different kinds of oral contraceptive pills. The duration of contraceptive pill was 14 to 28 days, which might also have an impact. But the most important bias of these meta-analyses, the pill-free interval was between 2 to 5 days. Now you have to imagine, we have seen that you need to have at least 5 days washout period. So imagine you start after 2 days with your stimulation. While you're stimulating, half of your stimulation, the patient starts to bleed. And a few days later, you have your pickup and transfer the embryo. Of course, the endometrium will not be receptive during this period. So this is why we published this paper together with Juan Garcia Velasco, stating that it is important to put in consideration the pill-free interval and make sure that the patient is bleeding. This is an important issue. Also, gene expression models have looked into this fact and they didn't find any significant difference. If you compare, now these are huge databases. This is 1,500 patients published from Belver in Italy, and in Spain, I'm sorry, Madrid, where they looked into this fact. And also they found out that if you do OCP pretreatment, you generate more synchronization, you have longer stimulation, more consumption, but there is no negative impact. This is from Juan Garcia Velasco again, 2011. If you compare a long agonist protocol, you compare it with the antagonist and OCP, the differences, the live birth rate is similar, 47, 44 and half. If you compare estradiol pretreatment, OCP, the results are similar. The only difference, as you can see, is the length of the pretreatment, which is significantly longer, because as mentioned previously, with the oral contraceptive pill, you have to use at least 14 to 15 days. This was published by Eric Hausmann, who was also working in Madrid at that time. Now, I think, Mr. Chairman, if you put together all the information we have seen, over the past, let's say 40 years, we have had the agonist, we have had the long agonist, short agonist, the antagonist. We had the first generation of antagonists, which was generating allergic reactions. But why do we administer the GnRH? We administer the GnRH to prevent the imminent LH surge. And this is exactly what the antagonist is doing. The agonist doesn't generate a suppression of LH immediately. The agonist, what it's doing, it's generating a flare-up. It's after the flare-up that you have the desensitization. So the antagonist is doing exactly why we are administering the GnRH analog, to prevent an LH rise immediately. If you compare all the studies we have seen between the long agonist and antagonist, the results seem to be comparable. We have shorter duration of stimulation with antagonist, lower FSH requirement, and similar perinatal neonatal outcome. And of course, the OHSS is significantly reduced. Why? Because you simply recruit a smaller cohort of follicles, and by that, you reduce the OHSS. This is in case if you would trigger with the ACG. But of course, with the antagonist, you have the feasibility to do your final oocyte maturation also with an agonist. And that agonist obviously eliminates almost completely the OHSS risk. Not completely, but almost completely. Now, of course, one of the reasons why patients drop out is also physical and psychological burden. And with the antagonist, that burden is obviously significantly reduced. Now, this is a graph which was published about 10 years ago by Paul Defroy, where he described the lessons we had learned over the past, at that time, 10, 12 years in Brussels, where we described how we would have done that at that time. So cycle day 2 or 3, you see the patient, you do a scan to make sure that there is no cyst formation, that the follicles are more or less synchronized. Then you start your stimulation. You see back, if you see there is a high responder, then you administer the antagonist on day 5. If it's a normal responder, you start the antagonist on day 6. Now imagine you have a patient who is a poor responder and there is no response after 5 or 6 days. Of course, there is no need to start the antagonist because there is no follicle to be ovulated. And we monitored at that time, still we do, the endocrine profile during the follicular phase, especially during day 6 and day 9, 10 prior trigger for the dose adjustment. You continue the antagonist, normally it's given in the morning and the FSH is given in the evening. And the trigger, again, the trigger is based on various factors. Usually we used to say as soon as 3 follicles of 17 millimeters, here you see between 15 and 19 millimeters. But again, I think we are learning that the time of trigger among patients will differ. I think the older patients get, the lower the ovarian reserve is, the sooner those have to be triggered. So you can trigger that patient at 15, 16 millimeter. If a patient is a normal or high responder with a good ovarian reserve, you can go up to 18, 19 millimeters. And the trigger, as you can see, if there is a risk of OHSS, you can always trigger with an agonist. And if there is no risk of OHSS, of course, you can use the ACG that you usually use. Thank you very much for your attention. I'm happy to take any question you might have.